Next physiological concept is airway resistance. You should know, students, what is airway resistance. Airway resistance is resistance to the respiratory tract to airflow during inspiration and expiration. So whenever air is flowing in the respiratory tract, there will be some resistance given by the respiratory tract. That is airway resistance. So again, it is simple school level physics. You must have learnt in your school days resistance. Resistance is proportional to 1 by radius to the power of 4. Resistance is proportional to 1 by radius to the power of 4. It means whenever there is airway narrowing, there can automatically be increased airway resistance. So this is nothing new. Whatever you have learnt in your school days, I am just writing it here. Airway narrowing will lead to increased airway resistance. Now what are the diseases associated with predominant airway narrowing? You know, students, one is asthma and other is COPD. In COPD, especially the subtype called as emphysema. Now why it happens in asthma? Asthma, it is due to allergen mediated. There will be allergen mediated inflammation. Because of this allergen, your body is going to give an inflammatory response, and products of this inflammatory response, there can be serotonin, histamine, leukotrienes. Serotonin, histamine, leukotrienes. All this will cause bronchospasm. So when bronchus is narrowed, there will be increased airway resistance. So asthma, it is allergen mediated inflammatory response happening in your lungs. Because of that allergen, there will be production of serotonin, histamine, leukotrienes. All this will cause narrowing of your bronchus called as bronchospasm. Then why it happens in COPD emphysema, I will discuss in detail in the next slide. Before that, you should know some basic respiratory physiology. There are two phases in your respiration, students. One is inspiration and other is expiration. Out of these two, which is slightly prolonged? Your answer should be expiration. The reason is, my inspiration is an active process. Body applies energy, so inspiration will be bit quicker. Whereas expiration is a passive process dependent on only lung recoil. See this, inspiration, active process, it will be quick. Whereas expiration is a passive process. It is only because of lung recoil, it will be slow. So that's why if you take in a normal individual, inspiration as 2 seconds, expiration will be 3 seconds. Total duration of respiration 5 seconds. Like that, how many cycles can happen in 60 seconds? 12. That's why normal respiratory rate, we generally take it 12 to 15 per minute. So write down, students, my inspiration is an active process. My expiration is a passive process. When compared to inspiration, expiration slightly prolonged, because expiration is dependent on recoil of the lung. It will be bit slower when compared to inspiration. Now, how is it clinically important for me? Suppose there is an obstruction in the airway. During which phase it will be more pronounced? During active expanding phase called as inspiration, or passive closing phase called as expiration. It will be more manifested during the passive closing phase called as expiration. So that is the reason whenever I give you my stet and ask you to auscultate for a sound called as wheezing, which indicates airflow limitation, when will you hear it more clearly? Expiration. So during expiration, obstruction of airway, more sin. That's why you find expiratory wheezing. Very simple logic, students. So this is your airway. So suppose there is an obstruction here. There is an obstruction here. During which phase it will be more manifested? During active expanding phase or during passive closing phase? During closing phase it will be more manifested. So whenever I give you my stet and ask you to auscultate for a sound called as wheezing, which will indicate airflow limitation, where will you see expiration? So very important points. Inspiration, active process. Expiration, passive process. Whenever there is an obstruction, it will be more pronounced during expiration. With this background, let us see pathophysiology of emphysema. So let us see pathophysiology of emphysema. Now normally at expiration, so let this be the normal behavior. Your alveoli are partially open. So why your alveoli are kept open? Because there is surfactant inside keeping it open. At expiration, alveoli are partially open. Not only the alveoli, the airways connected to the alveoli are also open. What is the reason? Around the airways there are elastic fibers. Around the airways there will be elastic fibers. So these elastic fibers apply traction, outward traction to keep airway open. So the point here is, normally at expiration, students, the alveoli are partially open and also airways connected to the alveoli are open. What is the reason for airways to be open? There are elastic fibers which apply traction to keep the airway open. Now if the patient develops emphysema, COPD emphysema, why it happens? Most commonly it is due to smoking, and it can also happen because of alpha-1, a genetic disease called as alpha-1 antitrypsin deficiency. Let it be any of these cause, students, the ultimate result will be increased elastasis within the lung. There will be increased elastasis. And if the patient is actively smoking, there will also be accumulation of so many inflammatory cells. There will be accumulation of so many inflammatory cells. Within the lung. First of all, let us see what these elastases are capable of doing. What is the function of elastase anywhere? Wherever elastic fibers are present, it will go and damage. Now what was the function of those elastic fibers? To keep airway open at expiration. So these elastic fibers are there. Now whenever elastic fibers are damaged, there will be early closure of airways, because airways are closing early. Air from the alveoli will not come out properly. Because of that, there can be air trapping. Now what is going to happen? There is damage to elastic fibers. So because of damage to elastic fibers, there is early closure. Of airways during expiration. Because of that, there will be air trapping in alveoli. Try to understand this very simple concept, students. For example, let this alveoli have 100 units of air which has to be expelled out in 3 seconds. Okay, which has to be expelled out in expiration. Now if this 100 units has to be get expelled, your airway should be open during expiration. Now your airways are closing early. So once the airways are closing early, instead of 100 going out, only 50 will go out in the alveoli. So how much is getting trapped in the alveoli? 50 units of air is getting trapped. During next inspiration, it is an active process, so 100 units will come into the alveoli. During expiration, again only 50 units will go out because the airways are getting closed early. Now how much is remaining in the alveoli? 100 units. See, very simple. So first time 100 units was there, 50 units were only going out, 50 was remaining. Now another new 100 units has come into the alveoli during inspiration. Now the volume of the alveoli is 150 units. Now during expiration, only 50 units will go out. How much is remaining in the alveoli? 100 units. During next inspiration, another 100 units air will come. So how much is there in the alveoli? 200 units. During expiration, only 50 units will go out. Now how much is remaining in the alveoli? 150 units is remaining in the alveoli. So previously after each respiration, not much was remaining in the alveoli. Now with each respiration, extra air is getting trapped in the alveoli. So as time progresses, all your alveoli will be over distended with air. So these over distended air sacs in emphysema, it is called as bulla. So as time progresses, these are the changes happening. So your airways will become more and more narrow, students. They will become more and more narrow, and there will be more and more trapping of air. So these over distended air sacs, they are called as bulla, because more and more air is getting trapped in the alveoli. There will be increased residual volume. Amount remaining in the alveoli increases because residual volume is increasing. Residual volume increase will cause increase in FRC and increase in total lung capacity. The lungs have become very, very big. All this is happening. Why? Because of damage to the elastic fibers. Now if you notice here, students, initially this was the radius of the airway. Now what has happened to the radius of the airway? It has decreased. There is decrease in airway radius. So whenever airway radius decreases, automatically what will increase? There will be increase in airway resistance. There is decrease in airway radius. So you can see the airway radius has decreased and the alveoli have become over distended. So these over distended areas are called as bullas. So whenever airway radius decreases, airway resistance will increase. Now if the patient is actively smoking, what else can simultaneously happen? So all these accumulated inflammatory cells will start involving the alveolar wall. So it will start involving the alveolar wall. So these accumulated inflammatory cells will cause involvement of alveolar, and so whenever alveolar wall is involved, the adjacent capillary wall will also be involved. Involvement of alveolar and capillary walls. So when these walls are getting involved with inflammation, now that wall is necessary for proper diffusion of gases. When it is inflamed, so the gases cannot penetrate that wall and go into the body. So because of involvement of alveolar and capillary walls, there will be decreased diffusion of gases. As a part of pathophysiology, these inflammatory cells will also be involving the alveolar and capillary walls. Because they are getting involved, now gases cannot penetrate that layer properly. So ultimately there will be reduced diffusion of gases. So ultimately whenever a patient is having a COPD emphysema, these are the pathophysiological changes. There can be decreased airway radius, increased airway resistance, so increase in lung capacity, decrease in diffusion of gases. Because of this, how will the patient generally clinically manifest? Now if you see the patient, because the lung volumes have increased, so the lung will not only expand sidewards, it will also expand posterior-anteriorly. So there will be increased AP diameter. So this increased AP diameter, what is this finding called as, students? It is called as barrel shaped chest. So write down, there will be, this is the anterior portion, this is the posterior portion. You can notice there is increased AP diameter. All this indicates that the lung volume has expanded. So this phenomena is called as barrel shaped chest. This phenomena is called as barrel shaped chest. Now if you see the patient in real time, this will be his position. So this will be his anterior portion, this will be the posterior portion. You can see there is increased antero-posterior diameter. Now what will be the gas exchange status of this patient? I told you, because the gas exchange areas are getting involved in emphysema, there will be impaired gaseous exchange. What will be the gas exchange abnormalities in this patient? Because the alveolar capillary wall is involved with inflammation, oxygen cannot be transferred properly. Patient will develop hypoxemia because of less transfer of oxygen, less passage of oxygen through the inflamed membrane. There will be hypoxemia. Now during expiration, normally air should come out. It is not coming out because of early closure of airways. During expiration, what is the gas coming out in excess? Carbon dioxide. Because carbon dioxide is not coming out, carbon dioxide will remain in the body. Patient will have hypercapnia. So there is a air trapping that can result in hypercapnia. Decreased transfer of oxygen that can result in hypoxemia. Then diaphragmatic impairment will also happen. What is the reason? Normally your diaphragms will be here and your normal lung will sit on the diaphragm. So if you consider this is the normal lung, so it will not give any weight on the diaphragm, so your diaphragm will move properly. Now in emphysema what happens is the lung will become this much. Now can you see the difference between these two, this lung and this lung? So the weight of this lung can be more. It will not allow diaphragm to function properly. So your diaphragm is the most important in a respiratory muscle. If your diaphragm is not functioning properly because of this big lung, so the respiratory effort will decrease. So whenever respiratory effort decreases during inspiration, patient cannot take proper oxygen because your respiratory effort has decreased. Expiration will also not be proper. So during expiration, carbon dioxide will not go out. See, your respiration is just like throwing a ball at a wall. So throwing the ball at a wall is active. So that is the inspiration. And because you have thrown it with good intensity, the expiration, the return will also be good intensity. But here what is happening, because respiratory effort is not proper, insufficient inspiration, insufficient expiration. Because of insufficient inspiration, oxygen will decrease. Because of insufficient expiration, carbon dioxide will increase in the body. In COPD, there will also be diaphragmatic impairment, and that will further increase the gas exchange abnormalities. So this patient with COPD will have both hypoxemia and hypercapnia. So generally, to know the exact amount of CO2, you need ABG, exact oxygen status also ABG. But one good thing for oxygen, we have indirect measurement, that is SpO2. So generally a COPD with worsening will present to me with low SpO2. Let us say his SpO2 is 75%. So in emergency department, when somebody is having low SpO2, what will you immediately do, students? You will give him oxygen. So you will give him plenty of oxygen. You will give him plenty of oxygen to bring the SpO2 to near normal. So normal, my target is 94 to 96 usually. Can you do this in COPD? Yes or no? Can you give excess oxygen in COPD and bring SpO2 to near normal? The answer is no. You should never give excess oxygen in COPD, and you should never try to bring the SpO2 to 94 to 96. So what is the reason behind this? Now COPD is a different disease when compared to other lung diseases. See, it takes about 20 years of smoking to develop COPD. Once the patient develops COPD, he can live with COPD for another 20 years. So during this long duration, there will be some permanent changes happening in his respiratory receptors. So generally, my respiration is taken care by two stimulus: hypercapnia, hypoxemia. So central chemoreceptors take care of hypercapnic respiratory drive. Peripheral chemoreceptors take care of hypoxemic respiratory drive. Listen carefully. Here is the logic. See, as years progress, this patient is always having a hypoxemia and also hypercapnia. So these receptors will be constantly stimulated. Now you are having a switch like this, and if you constantly press that switch, what will happen? After few days, the switch will stop functioning. In the same way, after few years, your central chemoreceptors become tired and they announce their retirement. So they give up. Now respiration is only taken care by peripheral chemoreceptors, and what is the stimulus for that? Hypoxemia. Now you can understand this concept equivalent to tendency of human beings. Now when you give them some work, few people will give up early, whereas few people will fight until their last breath. So these central chemoreceptors, they give up early, they stop functioning, whereas your peripheral chemoreceptors are very durable, they fight until the last breath. Now this patient's respiratory drive is only happening because of hypoxemic respiratory drive. Now if you give excess oxygen and you bring back the SpO2 to normal value, now hypoxemia stimulus is also lost. There is no hypercapnia, there is no hypoxemia, there is no stimulus to breathe, students. So what will happen? Patient will stop breathing, there can be respiratory arrest. So write down this reference from a new edition of Guyton. So he mentions that in chronic hypercapnia, as I told you, CO2 level may not stimulate respiration properly. So the central chemoreceptors become tired and they announce their retirement. Now these patients keep breathing only because of hypoxic drive. So what is making them to breathe? Hypoxic drive. Now if that hypoxic drive is withdrawn by giving excess oxygen, once you give excess oxygen and withdraw that hypoxic drive, breathing may stop, breathing may stop. Now what is the solution? So this is a lung disease. If you give excess oxygen and bring the saturation to normal, his breathing is stopping. But your organs, vital organs, require oxygen to function. So what is the solution? The solution is I try to give low flow oxygen. So instead of giving 5 to 10 liters on the flow meter, I try to adjust it to 2 to 3 liters per minute, low flow oxygen. And in COPD, my target SpO2 is not normal range, it will be near normal, 82 to 92%. I will not bring it to 94. I will always maintain a constant hypoxic drive. So I bring the target SpO2 to near normal. So still there will be some hypoxemia which will be stimulating the respiration. So the target SpO2 will be 88 to 92%. I will not normalize the oxygen. For vital organs to function, I bring the oxygen to near normal. So target saturation should be 88 to 92%. So in COPD, if a patient presents to you with SpO2 75%, don't give him excess oxygen like this. Give him low flow oxygen, and if they ask you what should be the target saturation, it should be not 94 to 96, it should be 92, 88 to 92. So this is the ideal treatment. Give him oxygen, but do not normalize the SpO2. If you normalize the SpO2, breathing may stop. The hypoxemic respiratory drive will be withdrawn and patient's breathing will stop. Patient's breathing will stop. So this is very important point that you should know in emergency department. So there is a patient with COPD, don't be very aggressive and give excess oxygen and kill the patient. Give what is required, and target SpO2 is 88 to 92%. So this is the first theory. And recent theory why not to give excess oxygen is, whenever you give excess oxygen in COPD, because of long standing and heterogeneous disease, there can be some ventilation perfusion mismatch also, that might also result in CO2 increasing in the body. But the frequently cited concept is this hypoxic drive, and the recent theory is there can also be some ventilation perfusion mismatch in COPD when you give excess oxygen. So but main concept that you need to know is the target SpO2 in COPD should be 88 to 92% only, 88 to 92%, and you should give low flow oxygen. Don't give excess oxygen, it can kill the patient. Let us see the chest X-ray findings. So this is a normal chest X-ray. So see, in the normal chest X-ray, you can see lot of curves like this. So a curvy diaphragm, a normally expanded lung, and a globular heart. See the curves, curved diaphragms, globular heart. Whereas in COPD, I know COPD will make you less interesting because curves disappear. See what has happened here. The lungs, they have become very big. So first important finding is bilateral, very black lungs, hyperinflated lungs, bilateral hyperinflated lungs. Second important thing, can you see the diaphragms here, students? Here it was a curved diaphragm, it was curvy. Here it is becoming flat and low lying. So there will be flat diaphragms. So you can notice flat diaphragms. What has happened to the heart? So heart in this side, you can notice it is globular shape. Now heart here has been adjusted like a tube. So this finding is called as tubular heart. So why these changes are happening, students? Again, it is simple common sense, nothing complicated. So when your lung was of normal size, your diaphragms were like this. So they were more curved. Now the lung has become very big. So it will apply weight on this curve. Because of this, diaphragm will become low lying and flat. And previously in this space, your heart was having a globular shape. Your heart was having a globular shape. Now whenever there is hyperinflated lungs, so the diaphragms are going down. So now this heart will adjust like a tube. The heart will adjust like a tube. So three important findings. Bilateral hyperinflated lung fills, curved diaphragms becoming flat, and globular heart becoming a tubular heart. So these are the important changes of COPD emphysema on the X-ray. Try to solve this question. A 70-year-old male with known COPD has been admitted with fever, purulent sputum, and increased shortness of breath. Whenever you find a COPD patient with worsening, this phenomena is called as COPD exacerbation. COPD worsening is called as COPD exacerbation. So patient is in exacerbation and his initial SpO2 was 75%. True regarding this case. Chest X-ray shows shrunken lung fills. No, we have seen hyperinflated lung fills. And oxygen should be prescribed. Definitely you should give oxygen. with target SpO2 94 to 98, it is false. You should give oxygen but target 88 to 92 only. Supplemental oxygen did not demonstrate the mortality rates in COPD. See, whenever patient requires oxygen, if you give it in COPD, it will improve survival, no doubt. In exacerbation, his body is having less oxygen, give him oxygen, his vital organs function will improve, it will decrease mortality. So it did not demonstrate decreased mortality is false. It can decrease mortality when you give it in emergency situations or when the patient requires. So this is also false statement. Higher concentrations of oxygen can blunt hypoxemic ventilatory drive. Yes. Causing CO2 retention. Yes. See, whenever respiratory arrest happens or when the breathing stops, from your body CO2 will not go out. So gradually CO2 will start increasing in the body. Higher concentrations of oxygen will blunt the hypoxic drive and it will cause CO2 retention. That's why in Western countries there will be oxygen alert cards given to patients with COPD. It will be clearly written, I am at risk of respiratory failure with a high CO2. Whenever I am ill, maintain by SpO2 88 to 92%. If I require oxygen, make sure you are giving low flow oxygen. So this is very, very important in emergency department students. So don't be aggressive and give excess oxygen. Give what is required is moral of this story in COPD. If you give excess oxygen, it can blunt the hypoxic respiratory drive, resulting in respiratory arrest eventually.